Here we would show how monitoring during or after therapy is meaningful. We can monitor the course of the therapy. We can directly observe tumor activity, detect minimal residual disease, and provide a basis for personalized therapy. This is one example. This was a 41-year-old patient with triple-negative breast tumor diagnosed in February 2023. And after neoadjuvant chemotherapy, she still had a quite big tumor left, a PT2. Therefore, she was, after surgery, further treated with pembrolizumab. Surgery was performed in August 23 and followed by radiotherapy and then adjuvant chemotherapy with capecitabine and the checkpoint inhibitor antibody pembrolizumab. The response to the combined chemotherapy and immunotherapy was quite nice. The decline of circulating tumor cells indicates that this therapy is efficient. So, monitoring of circulating epithelial tumor cells enables early assessment of the effectiveness of the adjuvant therapy and supports risk stratification for recurrence. So this patient is in stable, complete remission. Another patient, this is prostate cancer, which was diagnosed in 2007 with a Gleason score of 7, and there was a radical prostatectomy, but recurrence occurred in 2010 and again in 2021, where we started the analysis. The patient had a biochemical recurrence and cell numbers stayed nicely low under the bicalutamide. But after completion of the therapy, there was a strong increase in circulating epithelial cells, indicating that still the disease was in progression. And indeed, subsequent images confirmed the recurrence, which is not noted here. But the increase in CTC reflected progression of the prostate cancer, even in the absence of clinical symptoms. So now he has started again with bicalutamide. Third case, colorectal cancer, which was diagnosed in 2023. And this was a 47-year-old patient. The tumor was quite large, PT3. He was treated with surgery in April 2023, and then he received adjuvant chemotherapy with FOLFOX. After completion of this adjuvant chemotherapy, there was a decrease in circulating epithelial cells, and several months after the end of treatment, there was an increase. There is currently no evidence of recurrence, but the patient should remain under close surveillance. This is now a table of the clinical interpretation of maintrac results. So if there's a significant decline following initiation of therapy, there's a high probability that the therapy is working. If there is an increase followed by a decline, this is often observed in neoadjuvant therapy because there is an initial tumor cell release followed by subsequent tumor reduction. If this circulating tumor cell level is stable over a long period, this means there is a stable disease, but it should be monitored during the subsequent time for possible reactivation of these cells. If in some cases the circulating tumor cells are stable over a long period, but then there is a spontaneous decrease without ongoing therapy, this can show enhanced immune control. However, we have also seen redistribution of these cells. They migrate into the metastatic lesions, and this cannot be excluded if there is such a rapid decrease. If there is an increase during or after completion of treatment, this indicates that there is therapy resistance or looming recurrence or decreased progression. A decline observed during treatment, followed by a subsequent increase after completion of the therapy, indicates that there are resistant cells and treatment should perhaps be resumed. So, do you have any questions here?
Yes, there are some questions. How does maintrac stemtrac analysis integrate in clinical practice with established biomarkers such as ctDNA, tumor, and conventional serum markers?
It is known that the serum markers are not very reliable. See, the most of these markers are released by cells. It's proteins inside the tumor cells which are released upon cell death. And this is quite well known in prostate cancer, which is flare if the cells die due to therapy. But what we do is we are looking only for the living cells remaining in the blood. It's not really clear when these ctDNA is released, but the main release of ctDNA also is cell death. And that's why it is not detected during growth of the tumor cells, as long as no tumor cells die.
The following questions: are there any cases where circulating tumor cells and circulating cancer stem cells monitoring show superiority?
Well, we have published quite recently 2 papers on the increase in cells during the time of radiation, which takes quite some time. And we have shown that those patients with an increase in circulating cells during this time is followed by relapse. So there is a quite tight correlation between the increase in circulating cells and relapse.
How do you manage patients with inflammatory states where non-tumor cells express ABCAM?
Yeah, this is a problem for us also. In many cases in inflammation, the cells are rapidly eliminated by the white blood cells, but there are cases where we find elevated numbers of EBCAM positive cells, and I think the main approach would be to wait until the inflammation is gone and then see whether there are any circulating cells left. And if this is the case, then one can look for malignant tumor.
Which tumor types have shown the strongest correlation between circulating tumor cell burden and therapeutic response? Are there significant differences among breast, prostate, lung, and colorectal cancers?
It's not the tumor type, it's rather the individual patient's condition. And again, we do not just look for the number of cells. We want to see whether the cell numbers stay stable, increase, or decrease. And only an increase in cell numbers during disease is a sign that there is tumor activity and that this should be more closely observed. And in the guidelines in all tumors, it's only if these tumors are detected by imaging, then there is guideline therapy indicated. But there are other substances which we have observed can be beneficial for reduction of the tumor cell numbers.
All right, thank you very much. Then please go.